This was done by a colleague of mine. Intra-op, he had difficulty in dissection, and then after dissection he found that he was not able to remove the lenticule. This is a pre-op topography, very normal. And then after 1 week, the patient came back to me and he had vision of less than 660, and then this was a kind of topography. You can see that there is a lot of flattening here. Here you can see that there is increased elevation in the inferior portion. If you look at the OCT, you can see that the lenticule has got crumpled and pushed down into the pocket there. So that's how he was not able to find the lenticule, because the lenticule is all completely come down here. If you look at the thickness is increased in the inferior portion. There's a flattening superiorly. So he had very irregular astigmatism. This is the clinical photograph where you can actually make out that the lenticule is there in the inferior portion of the pocket. So he was not able to hold the lenticule. So after 1 week, 10 days, I went in again. This is a video. It was a big nerve, is a big nerve, so a 4mm incision there. So this is the worst complication where the patient had less than 660 vision on the first post-op day. Very irregular topography, but then I went in and then I was able to identify the lenticule. You can see it there. It's all crumpled up just in the inferior portion. So you had dissected the lenticule and actually pushed it inferiorly, and you were not able to find it, you were not able to grasp it.
It's made up of polymer, and that makes it very biocompatible material. It's also extremely flexible. This makes it much easier to implant. This is also removed in case you have a problem later on. So we do have different range of power available. So typically the range is, it starts from 3 diopters for myopia and goes up to 23 diopters, 20 typically. The higher ranges are more difficult. You need to really plan ahead. And the astigmatism corrects about 6 diopters of astigmatism with 0.5 increments. So this is how the lens looks like. As you can see, the marking makes it easy for us to ensure that you have it placed right. The convex side has to be placed up. So the mark has to have this mark on the leading right side. And we also have the marks for toric ICLs, which indicates the axis of placement. So detailed history is very important to look at the workup. History, because looking at refraction stability, contact lens wear, and for retinal barrage. If so, it's important to make sure we have a complete fundus exam either way, but more so in these patients. Refraction and maximum pupil dilation are important to look for, to see the pupil actually dilates well, that's when it's easier to implant the lens. And also to pick up any cortical spokes, any cataract which you might miss in the periphery if you don't have a good pupillary dilation. Slit lamp and fundus examination are important for complete anti-segment configuration, the depth both in the center and the periphery, and the retina and the vitreous, as is important in all high myopes. Parameters to be assessed pre-op would include intraocular pressure. So a patient who has borderline or high IOP, I think, are not good candidates, because these patients typically could land up with chronic glaucoma, especially we also get some steroids for some time post-op, and being myopes, you might have a patient with glaucoma. So you'd rather choose patients who have normal IOP. Gonioscopy is a must. They have to be open angle. Specular microscopy and excellent measurement is done. In addition, I think the most important investigation which will help us decide on the actual IOL design and the placement would be the op scan. And op scan is done to look for 3 measurements. One is the horizontal white to white. So horizontal white to white has to be similar for both the eyes, and based on this measurement is how you would plan for the sizing of the lens. In case the difference between the two is more than 0.5 diopters, I would do a digital measurement of the horizontal and white. So this probably is reliable as well, but I would go with the op scan first. So if you have a big variation between both the eyes, or you're having 3 measurements done and all 3 are at different ranges, then you would again probably have to confirm it with a digital caliper. The anterior chamber depth is measured, and the anterior chamber depth here, we don't include the cornea. It's from the endothelium up to the anterior lens surface. So that has to be also measured. And the corneal pachymetry, this probably, like I said, has to be at least about 3 millimeters to begin with. And corneal pachymetry is also checked. Prior to surgery, we typically do a peripheral iodotomy. Now I think this is not required with the new model. We had a center flow lens, which comes with the opening on the optic itself. But otherwise, we would need to do the PIs about a week or two before the actual surgery itself. You could also choose to do it on the table, but again, I would say if someone was just beginning ICS, it's better to plan for these PIs prior to your actual procedure. You would need to at least place 2 PIs, make it at least 0.8 to 1 millimeter in size, and in the superior quadrant. So this would be your what you would have to target. So tell the person who's doing the PI to make sure you have 2 large openings in the superior quadrant. So what do we, the ideal outcome should be to be able to have an ideal wall. The wall basically is the distance between the anti-surface of the crystalline lens and the posterior surface of the ICL. And this should be between 0.25 to 0.75 millimeter. So an undersized ICL will increase the chance of anti-capsular opacification, and an oversized ICL is also not good because it can cause forward bowing and can lead to IOP rise. So before I do this, I'll just go through one history. But this is not the ideal case to discuss, but I thought it would be a good, gives a good idea of what all can actually go wrong if you don't actually take care of do a good workup. So this patient came to us, was 24 years old, had high myopia with about 2.24 diopter astigmatism in both the eyes. Otherwise, his anti-segment was normal. His white-to-white and anti-chamber depth measurements were normal, and then we went ahead with the right eye toric ICL implantation. Post-op day 1, he did very well. He had 6.9 vision, 6.6 with pinhole. So the IOL, as you can see, ICL was placed at 175 degree axis, and this is where it was supposed to be. So this, he had the same, it was the same axis post-op day 1 and post-op day 15, at which time as well the vault was ideal, and so was the unaided vision. The left eye also underwent an ICL, and this eye the IOL had to be at 160 degree axis, and the patient did well post-op day 1 and day 15 as well. IOP was normal and the vault was about 0.75. 3 months post-op, the patient came back to us with defective vision of both the eyes. So he had fixed astigmatism, and he had about 3.5 diopters right eye and 3 diopters left eye. And the anti-segment OCT, the vault was normal. It was about 458 micron for the right eye and 429 for the left eye. So we were not sure why this actually happened. But anyway, when we look at the image of the placement of the eye cell on the eye trace, you can see it's about 98 degrees off axis. And you can see that the residual astigmatism was actually quite high, 6 diopters, but once you rotate it by about 98 degrees, you would have only a 0.09 residual. And this was the same for the left eye as well. For 115 degrees off axis it was. So this is how the lens looked. Instead of being at 175, it was almost vertical. It had totally rotated at the 3rd month post-op. So this patient underwent an IOL reallocation under topical anesthesia. And after the operation, the IOL was very close to where it originally was, about 16 degrees off axis. But patient did well. His UCDA and BCA was 6.9 and 6.6, and his vault was about 1.25 corneal thickness, and PI was paid. So patient was asked to come back, and the patient comes back after 15 days. But again, his vision drops, 6.24 and 6.6 with correction. The vault was for 415 micron, and the IOL was again found to go back to the original horizontal position where it was to begin with. That's the image of that eye. So this is like a typical, things can actually go wrong if you don't do a good workup. And just to see what could have gone wrong, refraction couldn't be an issue because the patient did well post-op day 1. IOL sizing was not an issue because the vault was good. There was not too flat or too steep, and the placement was fine because the axis was where it should be on day 1 and day 15, but the 3 months it rotated. So the 4th question is, the patient have a trauma, and the patient refused trauma, but one thing is both the eyes had IOL rotation. So we didn't recognize it as the first reoperation, but when he came back, we realized the patient had history of rubbing of both his eyes. That probably was the cause of the IOL rotation. So this is something which can actually happen. So a good history taking is also extremely important. So ultimately, I think proper patient selection and counseling, thorough pre-op evaluation, surgical precision, including the loading and placement, and good post-op care and regular follow-up are essential for good outcomes. Thank you.
Thank you very much, Dr. Aditya. We have Dr. Tityal here, so come and join us in the panel. Dr. Devesha will be speaking last but not the least on the most important topic, and that is honest and effective counseling. How to counsel a patient who has come for a treatment of refractive surgery, essentially LASIK, but you have to tell him that but you have to tell him that LASIK is not possible and phakic IOL is going to give him or her a very, very good refractive outcome. So I'll go on to the next part and supplement what Dr. Aditya said. The toric ICL, I'll just very briefly touch upon. You need to make the toric marking. And if you have to make the toric markings accurately for the accurate placement of the ICL, one technique is doing it on the slit lamp, making the beam horizontal and marking the patient on the slit lamp. This is a very inexpensive way and can be done extremely well. The other is, of course, to have the graduated calipers, and also we have the innovations. On the innovations, we have, I will share with you a small video by Dr. Owen Mahato. Can we have the audio on these as well? Audio
for marking the axis before toric ICL for quite some time now. This is basically an electronic camera leveling device. It has a set of 5 LED lights with a green LED at the center, which glows when the device is perfectly horizontal. There are 2 LED lights on either side of the green one, which glows when the device is not leveled horizontally. The device has a foot plate which attaches itself to the hot shoe attachment in the body of toric marker. Now the device is ready for use. Now you can see when the toric marker is tilted, according to the degree of tilt, the red LED or the blue LED glows, and the green LED glows only when the device is perfectly horizontal and goes off when it is not. The toric marker is now inked and is ready for use. The patient's head is positioned on the slit lamp chin rest. The marker is slowly advanced towards the patient's eye, and the patient is asked to look straight ahead. The marker touches the eye when the green LED light glows, thus providing accurate markings at the 0, 90 and 180 degree.
That was a very beautiful innovation by Dr. Owen Mahato of Disha Eye Hospitals. I'll go on to my actual topic and to do the right way, how to do an ICL and a toric ICL. So this again is a video presentation and it has a voiceover. Audio बढ़ा देना. To do an ICL the correct way. After proper preoperative evaluation and counseling, the Vision ICL is implanted under topical anesthesia. The cartridge is filled with methyl cellulose and BSS from the tip to the base. Any air bubble is removed from the fluid. When the ICL is in sodium chloride, V4, it is semi-hydrated and therefore takes 3 to 4 days after implantation to get fully hydrated. Due to this hydration, there are changes in the length and the optic size and the lens too, besides slight variation in power. Since Vision ICL V4C and V4B are the only model names come in BSS, it will have no change in diameter, optic size or power after implantation from what is labeled. The Vision ICL is withdrawn from the bottle with special applicator and lodged in the groove of the cartridge. The special ICL forceps is introduced from the tip and grasps the half-folded ICL at the base of the injector. It is gently pulled into the nozzle. The applicator is clipped into the injector. The base of the cartridge is inserted into the injector and locked in place. Two side port openings are made and methyl cellulose is injected into the anterior chamber. The amount of methyl cellulose should be such that it should not overfill the anterior chamber. The stream of methyl cellulose should just merge with each other during the injection. The main port of 3.2 millimeters is made. The injected tip is placed in the tunnel and gradually the Vision ICL is injected into the AC. The 4 footlets are gently tucked under the iris. The pupil is constricted and the incision sites are hydrated. For the V4C Vision ICL, no peripheral iridectomy is required. The V4C will only be available for myopia with astigmatism correction. For everything else mentioned, the model is V4B, no central optic port. The reason is that there will be visual artifacts or disturbances if we put a central optic hole in plus lenses which have thicker optics. The peri-optic ports are full length and 360 micron in each diameter. The ones on the foot plates are also full length but much smaller in size. The purpose is better fluid circulation around the crystalline lens and assist in visco removal. But these alone do not suffice the need not to have PIs. Therefore, PIs are required in a V4B model. During surgery, these ports can be utilized for faster visco removal by getting your IA probe near them. Please note the new toric markings on the lens body half extending into the optic region. Now, during patient follow-up, there is no need to dilate the eye to assess lens orientation in torics. Obviously, these lines are missing in spherical lenses. Do not expect the vault to change much from immediately post-op to any time later unless one has left a lot of visco beneath the lens. And follow-up, only in case of V4C, one might get a feeling on the slit lamp that the central optic port is slightly temporally shifted and therefore possibly a decentered lens. This is not true. Pupils are usually nasally decentered and therefore will give the impression that the port is more shifted to the other side. One would get this feeling very often. Please be mindful. Thank you very much.
Extra information. These are my financial disclosures. I have received travel support from Star at times. I've been a speaker for them. Basically, my topic is on recent advances in ICL. So we assume that you are all aware that it's a lens made up of polymer material. It started somewhere in 1988. There been several different iterations of this particular lens, and what we use now is the V4 with the inherent vault in it, wood plate haptics made up of an extremely biocompatible polymer material. The changes that have occurred is basically because of the innovations of Kimiya Shinzu of Japan, who essentially came up with the idea of making a small little hole so that aqueous can percolate from the back of the lens to the front without the need for a peripheral iodotomy. Basically, initially it was tried in the perioptic region, and subsequently now we have these 5 small little holes over here, one in the center over here, and then 2 on the sides, and then one in the right leading haptic and the left trailing haptic. And also you have somewhat extended toric markings over here, which essentially makes the lens so much more user-friendly and obviates the need for a peripheral iodotomy. So basically, each of these ports, I did hear Partha mentioning that the central port is of 360 microns and all others are slightly smaller. My understanding is all these ports are uniformly of 360 microns size. And this is essentially designed to facilitate OVD removal. It's not as if you leave OVD behind and subsequently blow it out, that the size of the hole is not enough for that. Basically, these helps OVD to circulate during the surgical process, and subsequent to the surgery, there is a more physiological outflow for the aqueous to flow out from the posterior aspect of the lens to the anterior chamber and eliminates the need for iodotomies, as I already mentioned. How did this concept of 360 microns be arrived at? Basically, these are based upon optical bed studies. If you have too small a hole, then it's going to be insufficient for the aqueous to flow forward. It's going to be insufficient for the evacuation of viscoelastic during the surgery, and there is a greater potential for these holes to be blocked. And also there can be something like a streaming, something like a fountain which is coming through these holes, hitting constantly on the back of the cornea, which could be deleterious to the endothelium. So this size of 360 was arrived at. They found that this does not have a significant impact on the optical quality, does not induce any glare or halos. Basically, if you look at the modulation transfer function test of these lenses, it exactly mimics that of the lens without the hole. Once you go on to a larger sized hole of 500 microns or so, that's when there is a difference that creeps in, and that's essentially the reason that all these holes are of about a uniform 360 microns in size. The other important change that has occurred recently is that previously the lenses that were supplied to us was given in normal saline solution, but today it's supplied in BSS, balanced salt solution, and because of which there's no expansion of the lens that takes place once it's implanted. Previously, if it used to take almost 72 hours for the lens to reach its normal shape and size and configuration. That's why even judgment of whether it's excessive vaulting or if the vaulting is somewhat suboptimal used to be done, ideally done 72 hours later. Today, the lens is exactly the size at which it's being placed in. This is the original V4 model, where you find that if it is 11.5 millimeters that we start with, once it is implanted, it reaches a size of about 12.1 millimeters. And because of this increase in size, which happens all around, there is a drop in the power of the lens from -10 to about -8 diopters. And as far as the optic zone size is concerned, it increases from 5.5 to 5.8 millimeters. That is the reason that these lenses are labeled as -23 diopters, but what they effectively corrected, correcting inside the eye is just about -18 diopters. Now with this V4C model, which is dispensed in balanced salt solution, what has happened is the dimensions are exactly what it is displayed. If it is 12.1 millimeters, that's exactly the final diameter. The optic zone size remains unchanged, and again it's -8 diopters, means -8 diopters is what you get. It is because of this that the maximum correction which is labeled on these lenses has also dropped down to -18 from -23. So this is the size of the kind of expansion that used to take place. Ideally in the smaller size lenses, it used to expand by about 0.6 millimeters. The larger size lenses, the expansion used to be by about 0.7 millimeters. V4 and V4C and V4B is essentially the same size as what is implanted inside the eye. This is just a small clipping of the ICL implantation being done. I think Bhargav has already shown you an excellent video. Let me see whether I can add to it. And that's it's being a polymer hydrophilic material. It's always dispersed in some kind of a solution, and presently it's BSS. Essentially, these are front-loading forceps. You put the lens on the cartridge and you draw the cartridge backwards rather than pulling the lens inside, and now there's no need for diluting with saline. It's essentially completely viscoelastic, and there's a toric lens which is placed about 5 degrees with clockwise rotation. That's why you see the marking being done over there. Essentially the markings are very similar to what we do for toric intraocular lenses. Please note that the side ports are made at 12 o'clock and 6 o'clock meridians, unlike closer to the temporal incision that we are used to with the conventional cataract surgery. And essentially I fixed the globe. This is a diamond plate which I am using, which is of 2.2 millimeters for my phaco. But since I want a 3 millimeter, you saw me slightly extending to the side. You do not do a wound-assisted implantation of these lenses, but ideally you have the tip of the cartridge inside the anterior chamber. That gives you much better precision of control. Basically, you constantly keep looking at the right leading optic, and that's why you should have that small hole over there, and that tells you that the lens is opening up the right way. These lenses are supposed to open up a little more, take a little more time to open up, but I have hardly found that something uncomfortable. You actually gives you a little more control. You are not supposed to do what I am doing right now in the center. Central optic is just about 50 microns in thickness, amenable to injury, so do not use any instrument on it. And this is just, the lens is always stuck in front of the iris, and subsequently through the side ports you gently nudge them with this the special spatulated instrument behind the iris. Basically, once you have it in position, then you can essentially those longer toric markings, which is a hallmark of this present day lenses, can be so positioned as to correspond with the initial markings that we made over here. Basically, it's done under topical anesthesia, and you load up the side ports as well as the central incision, and that surgery usually takes just about 7 to 8 minutes. And whenever bilateral implantation is necessary, though it can be done on the same day since it's a intraocular procedure, I prefer doing it at least in the 2 days or a week's gap. So these are the things. It's a fully hydrated implant is what we are doing. It's a thicker, larger, softer lens, and use only HPMC, no need to dilute it with saline, and it opens slightly more slowly inside the eye. Just some pictures. This is the original lens that we're using. Usually the eye drop, I always used to do a laser eye drop me about a week before at the time of ordering this lens, and you can see that ideally the position is somewhere under the lens. Superiorly, but once in a while you get a location like this, and this is the lens inside, and this is the current day lens. You can see the small openings over here. And this essentially shows an ideal one. This is one of our own cases where you see the thickness of the cornea and the vaulting is almost the same, telling you that it's about 500 microns. And over here, you find that this is again a picture of with the pupils constricted of the same patient. And this is the toric ICL being implanted. You can see the markings over here, which essentially tells you what is the orientation. So even if the pupils are not completely dilated, you can make them out. As far as the fine tips are concerned, one of the major concerns for getting the right sizing is to get the white-to-white measurement. Normally the instrument that we use is a digital calipers, which gives you in decimals the white-to-white, the horizontal white-to-white measurement, and that's what you use for your final calibration of the lens. You can also, definitely an instrument like a topolizer value or a pentacam will give you a better value, and Opscam will give you a better value. But essentially what you see over here is that the white-to-white, sometimes if you have a small pigment at the limbus, it could be erroneously picked up as an extension of the limbus. That's why you usually take both with the calipers and with an instrument like this and compare the white-to-white, and usually it should tally. It's extremely important that at least in certain areas you get the right white-to-white measurement, because if it changes from 11.14 millimeters to 11.2 millimeters, the size of the lens completely changes from 12.1 to 12.8 millimeters. So it's important for you to realize what are the areas where this transition occurs, because a small error from 11.6 to 11.7 millimeters would induce an increase in size of the lens about 0.4 millimeters, which could translate onto an excessive wall or deficient wall. Again, the vaulting is not just a function of the white-to-white measurement, also is dependent upon the AC depth. It's ideally, all these measurements are ideal for when its AC depth is 3 to 3.5 millimeters. When it's obviously a shallower eyeball, you need a smaller lens, and if it's a larger eye, which has larger anterior depth, you can introduce a larger lens. I think I would just skip through these slides. And as far as the lens powers are concerned, it's what is available up to about minus 18 diopters, plus 10 diopters, up to about 6 diopters of astigmatism. Between 0.25 to 2.75, it's available in steps of 0.25. And mind you, one good thing about is the effective optical zone size that you get on the cornea is about 25% more because of the proximity of the optics of the lens closer to the nodal point of the eye. So as far as the future is concerned, these are the concepts which might be becoming available very soon. Preloaded aspheric lenses which going through a 2.8 millimeters is supposed to be released in the ESCRS in a few months, may become available early next year. Very soon they claim that the multifocal and toric versions will come in, and V7, which is supposed to have one size fits all, where white-to-white measurement need not be taken. Optimal vaulting might be there in each and every lens that you implant. Thank you so much for your kind attention.
Thank you, sir. Thank you very much. There are a few seats here available. You can come in and sit here if you wish in the first row. We'll go on to the next topic after Dr. Ramurthy, Dr. J.S. Tetial to speak on complications and management of VT5L.
Thank you, Pastor, for giving me this opportunity to be with all of our friends, because this is a very important area. People do a lot of refractive surgeries, and we have just heard speakers the various ways to handle these cases in an appropriate manner. And once you do surgeries, complications are bound to happen. And it is important for us to know what type of complication we see and how to manage those cases or steps which you encounter, so they get a best outcome of these cases also. So you always know there will be intraoperative problems and post-op problems for any surgeries, post-op for a refractive phakic also. Right from taking out the lens to load it, to inject it and place it, you can have complications as such. And subsequently post-op period, wide range of complications do happen. If you look at a few important things which we have been highlighted by previous speakers, another thing which you might encounter is you can damage the lens while taking out or while trying to pull it through the cartilage. And another mistake which we had done earlier was, I had done personally for one case, was I used only VSL solution on the cartilage, no methylene. And by the time I was pulling the lens, the VSL had gone and the lens got stuck onto the surface of the cartilage. If you pull it, you can damage the lens, and you can chip the lens. Therefore, methylcellulose addition onto the cartilage is very, very important, because that will lubricate the cartilage, and pulling out this material will be easier. Therefore, the grabs should be proper, and the pulls should be as Dr. Ramamurthy stressed. Your left hand should be, retracted backward, rather than pulling for your right hand if your right hand is surgery. And you can drop the lens. It's very important to have a lens in proper place onto your applicator, and if it is a horizontal position like this, it's better, it's more stable. And the new faucets which they have provided us, which has a wider surface to catch, is always much better to safeguard the chipping of lenses which can happen in these cases. Second important area which is important is damage because of new constructions. We all have been doing cataract surgeries, and we are not worried about what is there in the antechamber, because as such we are going to remove the anterior capsule portion. But here, if you damage the anterior capsule, the entire surgery is really damaging as a refractive surgery concept. Therefore, you have to be very careful when you're putting a keratome. That is a 3.2 keratome, and make sure that my plane of work is much parallel to the corneal than towards the lens surface. And if it is under the viscoelastic cover, if you do the second side pull first, then it is always better to do under the viscoelastic cover. You will not damage the chamber, especially the sudden jerky inching which may happen in your cases. If you are using a reused blade, Indian blade, sometimes you have to really make a way through the cornea and lippers, and you can damage the lens at this stage. Same goes true for a side pull entry also. If you see my blade orientation, the tip doesn't cross too much onto the antechamber. If you cross too much, the chances of damage to the anterior capsule is very high, especially if you are right-hander. The inferior side force is done by left hand, it always can be a problem in your case. So you have to be a little careful there. Excessive entry of viscoelastic on the antechamber can also be very, very damaging. If you see here, the viscoelastic cannula is also near to the edge. Never put your viscoelastic cannula to this side, which is not good for cataract surgery. So you have to avoid that cataract feeling of a surgery, comfortable zone, away from that, and be near to the wound area. Inject viscoelastic from here so that it pushes a little aqueous towards the side port so that it don't inflate the chamber too much. Otherwise, the iris may revert backwards and it may get opposed to the lens surface and difficult to unfold your lens. The few of the complications which may happen during insertion is, I'd like to take you to sometimes ICL can get stuck on the wound area because you are doing a wound assisted insertion sometimes, and forceful injection of ICL can really hit the lens iris and pupil and can cause problems. Sometimes in reverse opening or inverse opening can be there. You see this brief video of mine where the lens got stuck on the wound area. You see the lens is already there, and while I was trying to withdraw, the viscoelastic also came out and it was stuck here. The lens is still stuck here and it's not open out. So if you handle this uncarefully, you can have a reverse folding. So I'll inject the viscoelastic, just try to tuck the trailing haptics and it will open slowly. You should not be panicking at this stage, form the chamber, and slowly re-manipulate the lens, it will open again. And inverse opening is possibility is there if you use too much of viscoelastic in the antechamber, or I use sodium hyaluronic. Sometimes that can be a problem here. You see here, I'm going quite slowly, I'm trying to manipulate my right hand directions so that it opens slightly, but despite that it will opening to the reverse side. So at this stage, don't push it, hold it here. You have a side cord here. With this, you can just tap it the outer surface of the lens and it will open. So you can still hold it and you can do it rather than trying to inject further and it will open reverse and you'll have a lot of difficulty. So that step will really safeguard your position at that time. But if you have really gone inside, the lens will open inside, then what to do at this stage? If you see here, normally the lens edge, this outer trailing edge will be over the iris surface. So you have to just put little more viscoelastic underneath this trailing haptic, lift that, hold that with the forceps, and you can easily pull it out. See here, I'll just hold here, just pull it to one direction with one little movement up and right, and the entire lens comes up. So this is the right way to handle if you have a reverse opening inside, rather than trying to lift or turn the lens inside out in the antechamber. In that process, you damage the lens capsule or you damage the endothelium, and you can have a very difficult position. So you should take out the lens, re-inject in a safe manner in these cases. Sometimes the lens stacking problem can be there. If you see here, the lens may not be clearly visible. You have to go over the iris or below the iris. Never try to lift the pupillary edge. In that process, you will touch the lens surface and cause no problems, or you will hit the angle area, bleeding may occur. The best way to just push the lens or pull towards you, and that will show the edge, and you can just rotate a little bit towards the anti-clockwise, and this haptic will go inside. So never try to manipulate the pupillary margin with your instrument, and that's how it will safeguard your complication related with this. So if you see here, one problem we discussed was toric ICM, because large number of patients would be having a toric indication as such. This is one of the first toric implantation I had done around 2005, and a post-op period, you can see one suture here also. So my axis I deviated by more than 27 degrees. It was supposed to be at 11 degrees, it was at almost 155, 160 degrees. So I have recalculated the axis. This is a mark where it has to be there. You can see a toric axis here. The main reason to show this is how to re-rotate the lens. Inject little bit of viscoelastic over the lens surface. Don't inject too much, otherwise you will get stuck to the lens surface. After that, little bit of viscoelastic in the space which is here. That will give you a space for a lens rotation. Little viscoelastic, and lens is free now without opening the main wound. Otherwise you lose the chamber and it will be very difficult to rotate. So once you have viscoelastic cover over and little under, then you can easily rotate this lens without jeopardizing the lens capsule or your pupillary damage. It may happen with the resurgery in this case. Make sure again your lens is right in the center, the axis goes to the place which you want in these cases. If your initial calculation of a lens sizing would have been correct, the lens will not re-rotate to the other positions. But if your lens sizing is a major problem for re-rotation or rotation of the lens, you may have to replace the lens with a proper sizing. So that has to be understood for all ICL patients where a lens is rotated in the posterior period. One of the main cause can be a poor sizing of ICLs. Lens opacities, as you know, can be the major hurdle for all phakic IOLs. That's a major concern for pre-op counseling for our patients. Incidence is around 5% in the literature, but it can range from various percentage to 40%, mainly because of surgical trauma or at the time of surgery, or poorly placed ICL onto the lens surface. You see here, a little bit of anterior subcapsular opacities do happen in most patients. They are non-progressive. They don't cause any visual loss in these patients. If your bulk is correct, so you don't have to do anything in these patients, especially for vision is good, and keep observing these patients. But if you have progressive lens opacities in the center and cause visual loss, and lens is too flat, then you may have to take it out and do a cataract surgery also. Cataract surgery is not a big problem because IOL power calculation is not a major problem for these ICL cases. These are various causative factors. Mainly the previous design lenses had a more incidence of cataract rather than newer designs. They also. This is an immediate post-op period with a high pressure and inflammation that has to be taken care of. Endothelial cell loss do happen in these surgeries also. But mainly it is a one-time surgical insult, and subsequently in a 1 year, 2 year follow-up, people have not found a significant higher cell loss in these patients as compared to normal patients. Detachment and deformities can occur in these patients. A little bit on a very side lenses, which we used to do earlier. We used to see patients with inflammation, dislocation of very side lenses, and the percentage can range from 0 to 30%. And once they are dislocated, vision goes down. If you put it back, vision comes back, but endothelial cell loss goes down by another 10 to 20% in these patients. Therefore, bullous keratopathy chances are much more in these cases. They are all high myopic patients. They can have posterior problems. I had in my 80 patient series of 5 years around 1 retinal detachment and 2 cases with a subretinal coin-shaped hemorrhage happening in the macular area and losing vision. So these possibilities can be there. In ICL also, post-traumatic anterior dislocations are reported. This is one of my patients, and subsequently we have to redo it, and later developed cataract, and the cataract surgery has to be done. To summarize my talk, complications, as I said, do occur in all surgeries. It is there with phakic IOLs also, but fortunately they are very, very rare, and they can be managed without any significant damage to the vision of most of the patients. Therefore, case selection and better surgical understanding would be the right way to go for these cases. I would just show this slide. You are invited to RP Center Foundation Day on 9th and 10th March. And we have 1 day CAD also, and you can register if somebody wants to take form. They are available in American staff. Thank you.
Thank you very much. Our next speaker is Dr. Sri Ganesh, someone known for his excellent surgical skills, and from him we'll see how challenging cases in phakic IOLs need to be addressed. Sri Ganesh.
Good afternoon, dear friends. Thank you, Dr. Partha, for inviting me to this hall-filled IC. Very pleasant to see a refractive hall so full. I'm sure it's because it's your book. Congrats. And now we look at some of the challenging cases I've had. I've been doing phakic IOLs for over 10 years now. ICLs have put in nearly about 2,500 lenses, and we have had some challenging cases. The first one, which I'm going to show you, we got a couple of awards. It is Phaco with ICL Institute. This was a very interesting case. It was a case of high hyperopia. This patient had about a very high hyperopia, and we had put in a 12 diopter ICL in this patient, and after 1 year he came with this picture of anterior subcapsular cataract. So we had to, there were different options. One is to remove the ICL, do a cataract surgery, put in a lens. We did the biometry. The biometry showed 47 diopters, as a required IOL, and you don't routinely get 47 diopters, so you either have to have a customized lens or you needed to do piggybacking to correct this high hyperopia. The other, so what we decided to keep the ICL as it is and do the phaco under the ICL, remove the cataract and put a standard lens. So the ICL which is there acts like a piggyback lens. And this is something which we attempted. So I'll just show you the technique. This is a young patient, 20-year-old. As usual, under topical temporal corneal incision. And then what I did was I just lifted the proximal haptics there near the wound and into the antechamber. Then put in viscoelastic first above the lens and then in between the lens and the cataract. Now I'm doing the capsulorhexis under the ICL, you can see that. And sometimes younger patients, it is a little difficult with the soft cataract. So I've done 3/4 of the rhexis, then I change over, use a forceps to complete the rhexis. So all this is being done under the ICL. So this is a 2.8 mm incision. So you don't have to remove the ICL. This patient was very unhappy when he developed a cataract because he had good visual recovery after the ICL, was very happy with his ICL. You can imagine a very high hyperop over 10 diopters of hyperopia. And that's the rhexis which is completed in hydrodissection. Since it's a very soft cataract in a young patient, we just use the irrigation aspiration to aspirate the cataract and the cortex. Now, what diopter of lens should we put in? We decided to put in a 22 diopter lens as a standard lens. But again, this poses some challenges in biometry. If you want to keep the ICL in situ and then put a lens in the bag, then what is the diopter? How do you calculate it? It's very difficult. Since the patient was almost emmetropic, we thought we'll use a 22 diopter lens, so a standard lens between 20 to 22. But again, there are a lot of factors which come into play here. It's a short eye, so again that poses challenges in biometry. Then the other thing is effective position of the lens, both the intraocular lens and once you remove the cataract, the ICL also, it changes. The effective position of the ICL in relationship to the pseudophacos, that also again is a little complex. You can see that we have cleaned the cortex completely. Then open the bag with viscoelastic and then put in the standard 22 diopter lens into the bag. That's injecting the lens. Actually, the ICL acts like a shield and it prevents any endothelial damage when you're doing the procedure. There is a layer of viscoelastic between the ICL and the endothelium. So you inject the lens and then once that is done, once the lens is in the bag, then you just tuck in the haptics under the iris. And that was the end of the procedure. The patient post-operatively had about a residual 3 diopters, 2.5 to 3 diopters of hyperopia, but still he was happy even with that. He was able to manage most of his activities, vision cleared. So this is a very innovative technique where you can keep the ICL in situ and then extract the cataract and put in an IOL. Only thing is it poses some challenges in biometry and we need to look at how we can go about doing the biometry so that we get an accurate power of the lens. That's just aspiration of the viscoelastic and you can see that that's the end of the procedure. This is another very interesting case. This is a 40-year-old male who had high myopic astigmatism and -11 with 2-cylinder. And we did a toric ICL post-op. He has 6/6 vision. After 1 month, he came with blurring of vision in the left eye. Right eye was okay. Left eye, the vision had dropped to 6/18. We did a refraction and it showed plus 0.5 with minus 4 cylinder at 160. So obviously the ICL had rotated. These were the details of the ICL implanted. It was a V4 12 mm, minus 18 plus 3 silk at 72 degrees, and the pre-op white to white was 11.4. On dilatation, there was a 70-degree rotation of the ICL, so we thought we'll just reposition the ICL, and we did that. But again, after 15 days, it again complained of blurring of vision, and we saw that it had again rotated. So this is the procedure, initial procedure, where we actually try to rotate the lens. You can see we have marked the 0180. The lens had rotated. The lens was supposed to be in almost 15 degree position, and then it had almost rotated almost by 70 degrees. So we rotated it again, and you can see that this lens easily rotates. We are just holding the periphery. You should touch the optic area, that is no touch zone, and then we reposition it to the 15 degree mark and align it. And then I'm wondering why it rotated. When it rotates, actually you have to recheck the white to white. We rechecked the white to white. It was fine. The left eye was fine. The left eye also had a 12 mm lens. Both eyes had a 12 mm. The vault was okay. So I'm again rechecking and seeing whether it's positioned properly, because this patient was very apprehensive. Put in viscoelastic and rotated the lens, rechecked before removing the viscoelastic, and you can see it is at its 15 degrees. Then I didn't open the main incision. It's only through the side port that I did this maneuver, and then washed out the viscoelastic. Now I'm hydrating the wound because the procedure is over, and then watch very carefully. Again rechecked, hydrated a little, rechecked, still at 15 degrees. Then somehow the eye was soft. Again, myopic eye is a little soft, and I decided to think it is a little soft. So I decided to pressurize it a little more, hydrate the wound a little more, and you can see what happens. See? Okay, in slow motion, see that again? The lens rotates back. It's almost at 90 degrees now. So obviously there was some problem here. The lens was too small for this eye. So re-rotated it, kept it in position, but I knew it might not stay there. I was keeping my fingers crossed, and I didn't have another lens. And what we did was post-op, again this patient after 15 days came back with blurring of vision, found that the lens had rotated. We did a UBM, and in the UBM we found that the sulcus to sulcus was not matching with the white to white. There was an anatomical discrepancy in this eye. The sulcus to sulcus was much larger. It was, I think, around 12.6 or something like that, 12.6, 12.7 on the UBM. And then what we decided was, yes, this lens is no way going to be stable in this eye. We need to exchange it. So we ordered a 12.5 mm, the next size ICL, and this is the surgery of the exchange. You can see that I put in viscoelastic, and then the proximal haptics are first lifted out. Now you have to engage the lens, and then this forceps which they give you is very thick. So engaging it is a little difficult. So what I do is I go with the Woolkitch manipulator and then just stuff that lens into the jaws, and then you can see with a side-to-side movement I'm able to gently remove the whole lens through a 2.8 mm incision. But the pupil has constricted a little, put in an adrenaline, but still it's not fully dilated. This is the new lens which I am again inserting. Unfolds slowly, and of course this is the usual steps. You have to be very careful. Sometimes this lens could have gone the opposite way, but you saw that maneuver. I put in viscoelastic under the lens and then it opened up the right way, position it correctly, and then once I insert it, this is the V4 lens, the previous model of the V4C. When the pupil constructs, you have to literally pull the haptic quite a bit, bend the lens and then tuck it in. It's a little bit of a challenge with a smaller pupil when you want to put it, but when you're doing an exchange, you should be prepared for this, that the pupil can come down. And you can see this is a much larger lens, it sits better, and I just check the axis for it to be placed, and then it was very stable. Post-operatively, at the end of the procedure, post-operatively the patient did very well and is very stable. So the take-home message is that occasionally you can get a patient where the ICL rotates, and before you take it for re-rotation, always do a UBM, check the sulcus to sulcus whether there is any discrepancy, recheck your white to white what you have measured before and whether it's the same, and then you can look at whether you want to re-rotate the lens or whether you want to exchange the lens. Thank you very much.
Thank you very much. The surgeries that you showed were excellent. The second was very, very nice. The first, I think I'll take up a court martial session in one of the court martial sessions. I promise you that. But Dr. Ramurthy needs to leave, and if there are any questions for Dr. Ramurthy, could we have quick one or two questions? I'll ask a quick question. Yes, sir. Yes.
My question is sir.
Yes.
You did cataracts here in the ICL.
Can we use superior incision also to putting the ICL, more especially when we have estimated of 1.5 or 1.2 minus 16 or minus 14 spherical powers?
The ICL is always placed at the 0-180 degree.
So why? Supposing there is,
because the astigmatism is always corrected so that the lens can be placed in the 0-180 degrees with a maximum rotation of 22 degrees. Maximum you can rotate it in either directions, clockwise or anti-clockwise, 22 degrees. The lens is manufactured like that with the cylinder in the plus axis. If you're comfortable making a superior incision, then even if you inject the lens to the superior incision, you have to position it horizontally, but it's a little more difficult. Plus, a superior incision would induce surgical astigmatism than a temporal incision.
Actually, I have done.
The astigmatism of 1.5 diopter or less than that, say 1 diopter.
Probably.
It is at 180 degrees. I want to, reduce the astigmatism by giving the incision at 12 o'clock.
If you want to use just an ICL and not a toric ICL, simple ICL, then you can combine it with LRIs if the...
Actually, I have done what you have suggested, especially though by convention we do a temporal clear corneal incision, when we want a 0.75 or 1 diopter of astigmatism, that is with the room, and you want to get some kind of astigmatic correction, I do a superior clear corneal incision, and especially in these younger individuals with a 3 mm incision, it does address about 0.75 to 1 diopters. So though it's not as accurate as a toric intraocular ICL, you can debulk the amount of astigmatism that you leave behind by positioning this incision when you're using a spherical ICL.
But in that case, white to white has to be measured in horizontal meridian or vertical meridian?
You are absolutely right on that. In that case, it should be measured on the vertical meridian. But frankly, I have not done that.
No, the company will not, because
they did not.
No, the lens is always placed in the horizontal, never in the vertical. Because if you place it in the vertical, then your vault will increase, then your risk of angle closure glaucoma is more. So even if your incision is superior, the lens has to be rotated and placed always in the horizontal. Because all the measurements, it's manufactured, the nomograms are all for the horizontal placement of the lens.
That is my question. Why it is so? Why can't we measure the vertical meridian white to white and give it to them and they...
That is the way the company has designed the lens.
Any experience with the Indian...
Most of the equipments also give a horizontal white to white meridian. And the larger space is the horizontal white to white rather than the vertical meridian. So orienting them and rotating them, even if I introduce it in a vertical direction, rotating them in the horizontal is not too difficult.
Actually, that's the crux. The measurement is always taken in the horizontal white to white. Therefore, the manufacturer does it in the white to white, and transposition of the cylinder is also to be done because of the white to white and the horizontal axis.
The other region would be, the largest length of a sulcus will be horizontal. You are measuring the lens as per that diameter. It will be larger for a superior side. The rotation of this lens to superior other side is less. If you put a lens to superior side with a smaller sulcus, the rotation of the lens to the other side is much more. The predictability of rotation. So you place the lens like this because sulcus is bigger here, the lens rotation can be there. When if you put it here, because the other sulcus is smaller than the horizontal one, the chance of the rotation will be less.
Yeah, Dr.
Sir, this is other way around. The sulcus, white to white is more horizontally, but the sulcus is more vertically. Because once you have a larger wall, the company recommends you can rotate at least the spherical ICL vertically. That will decrease the wall. And there is a study by Shimuzu et al. It was presented at this time in ICL meet. Wherever the volt is too much beyond 7 or 800 micron, and you have put at least you have a spherical ICL, you can rotate the ICL vertically. That will decrease the volt. And the second thing is, I have done quite a few of these new model toric ICLs also, as well as spherical ones. The volt does change. It's not fixed on day 1, 2, and 3. The reason I don't know. Maybe there is a dampening effect of the RS, because I have seen once the pupil dilate, the volt increases. Once the pupil constrict, it decreases. And also the studies have shown that the volt does change with accommodation also.
Thank you. Sir, can I ask a question? Yeah. Any experience with the Indian company making IPCL? Is it similar or?
The Indian lens, yes. The IPCL, I do not have any personal experience, but we had one implanted recently in our conference. The lens is a little stiffer. The material is different. But the company claims that the vault is more stable because the lens is a little stiffer. And it uses the regular butterfly cartridge for it to be injected. It doesn't have a hole in the center, but it's got perioptic holes. You still need to do an iridectomy with this lens. Long-term results basically are not known. We need to just look at it long-term and see whether the material, the interaction, the incidence of cataract, glaucoma, all those things. Because the ICL has been around for now more than 15 years.
Basically, the attraction about the ICL in its present form is a polymer material. It's perhaps the most biocompatible material. It's something which is rubbing constantly on the back of the iris, very close to the natural lens. So obviously you need a material which is going to, and you're putting it in young patients. So it's tried and tested, and we do not want to end up with something, a flurry of cataracts happening years later. Having said that, this IPCL right now, as I also have not implanted it personally, I am told is made up of hydrophobic acrylic material, similar to the lens material that's being used. Hydrophobic. Whether that is the ideal material for putting in the sulcus is something that only time can say. But having said that, I think we should welcome the idea that something else is coming up, because of the cost is wonderful technology, its usage is limited. I think if some other alternatives do come up over time, that's something we should welcome.
The main advantage is the polymer causes a layer of fibronectin, which coats this lens and kind of isolates it, it sequestrates it from the inflammation, so the lens is very clear. So we don't know how the other material will react.
ACD measurement.
Last short question, yeah.
ACD measurement by ultrasound is reliable enough, or
ACD measurement by ultrasound. The best measurement of the ACD is by the OpScan. The Pentacam also gives a very good measurement. So the ACD measurements need to be done by these two.
The only aspect you have to remember is that IOL master usually gives any laser interference biometry gives about a 0.5 millimeters higher. So please don't go by that. Then you will get a excessive warping. But usually white to white is 0.5 millimeters higher, not ACD.
Let's go on to Dr. Devesh Shah, and I think this is the most important, and he's going to give us real good take-home messages about how to do an effective counseling for a refractive surgery patient.
Good afternoon, Ram, and thank you, Partho, again. And I must, before I start, I must congratulate Partho for the increasing popularity of this IC. Since last 4 years that he has been doing, the crowd is swelling more and more. And I would like to congratulate Partho again tomorrow for your election day. And to start with the counseling. So when a patient comes to you for refractive surgery, why we need to do counseling? And why he comes to you? He needs to talk to you about taking an information for the procedure, whichever procedure it is maybe ICL or LASIK or whatever. He would like to know what type of experience our patients has with this type of procedure, and of course, the most important, the price. So we should be very thorough with our knowledge about the product. We should sound very confident when we talk to the patient while counseling, and all the staff of our center who come in contact with the patients should have some knowledge about the procedure, so that when the patient, or most of the patients do have a tendency to talk around when they are waiting in the waiting room. So we should talk in such a way, and the counseling should be in such a way that, if possible, and if everything is right, we should convert that consultation into business. So we definitely need a very good counseling, because all the patients who come into our clinic to talk about refractive surgery or phakic IOL, they have lots of misinformation, and especially about the complications. And most of the surgeons the patients are young, and they are very knowledgeable about the internet, and they have without any doubt gone through the problems about the phakic IOL or LASIK or whatever. So they have lots of misinformations, and we have to clear those misinformations. So we can take offer them a lot of options, solutions about their problems. We can talk about their vision and alternatives available. And it should be very clear to the patient's mind that phakic IOL is not an alternative to LASIK or vice versa. It's a choice which lies mostly with the doctor, and the patient also has to add up. And the clinic should not be identifiable only as a LASIK clinic. That's important. So we should give the information to the patient, and patient is also expected to ask for information. We just cannot open up like that, and we should allow the patient to make an informed decisions. And once the patient hears something negative before they make the decision, they are definitely very likely to lose their interest. Like there will be objections like, I have never heard about ICL before or phakic IOL before. So we should be ready with answers like this, that ICL is implanted every 5 minutes all over the world. It's a premium choice for the US military, and it's been around in India for more than 8 years, and it's been done in the world for more than 16 years. Again, like LASIK, we should say it's a procedure, it's not an operation. Operation is a very difficult word for all the patients, whatever it is, whether it's appendix or whatever, or it's an IOL or whatever. So it's a procedure. And we should, when we talk about the fees, it's better to talk about one eye rather than talking about both the eyes together, which makes it look quite big. And we should also impress upon the patient that it's a new, most advanced technology available. The patients like to hear these words. And we have to keep on talking about the options and the negatives and positives about the procedure and the other procedures, and we have to reinforce what we want to say. We must have brochures, signages in our waiting room to support what we are seeing inside our clinic. We should talk about the success stories. Like what we do is we have patients talk about this procedure. We have taken videos, and there are clippings of those videos, and we can show them to the prospective patients, and that really helps.
We can provide links to the patient's blogs, and we can also provide links to the data available on the internet. So pictures like this or the patient's inputs like this, it really helps. They really take this procedure with a positive mindset, and then they like to listen to what we are saying. We can show them these pictures also, before the procedure and after the procedure, how the look changes. And believe me, it's important to put into the patient's mind that when he comes in for the procedure, we are together till the end of the procedure, and even after that, till he becomes absolutely fine. So we should talk about the procedure like it's painless, 5-minute surgery. There is a very quick recovery with almost immediate vision. This is not like a transplant or organ transplant and there will be a rejection. There is usually, this is not like that, so you have to be on the medicine for a long period of time for the body to accept it. There is no maintenance cost to this. If needed, very rarely, it is reversible, and there is no stitching involved in this. Less than 1% chance of retreatment. And in the end, but most important, is that patient must understand that the visual quality that he will get after the procedure will be excellent. And there will be no night vision or halo, or very rarely halo that flares. This is very visually very pleasing to the patient. There is no bleeding involved, no pain, no hospitalization. Maybe initially we can do ICL with, after giving a perivalvular anesthesia, but we can eventually move over to topical. And as I said, it gives excellent quality of vision. And we should not forget to add this to when we are counseling, that it is approved by US FDA, it is approved by the US military, it is CE marked for Europe, and it is also approved in India. And such huge numbers are being done in India now. These things should be clear, discussed very clearly with the patients, with definitely very cool head, because patients are expected to come out with very difficult, irritating questions, but we must be ready for those. And of course, when we talk to the patients about a procedure, we must never forget about the possible risks, benefits, and complications. We must also talk about the post-surgical outcome, what he should expect to do after the surgery, and what type of discipline he should maintain. So there have been so many literature supporting it that implanting exact IOL is superior to ablating cornea, especially when the power is more than moderate, and the visual quality is much superior. And we must explain to this patient, do everything to the patients verbally and in writing before the patient comes in for the surgery. And as usual, we must limit the expectations of the patients that we all do, even while doing LASIK. The considerations have been talked about before, but as we all know, the patient is bound to ask that why I can't go for LASIK and why you are talking about making IOL. So we must be able to explain the reasons for this. And we must ensure top level commitment and deliver the best. It's always best to talk truth, as often the surest way to convey information is to tell the strict truth, as said by Mark Twain. Thank you very much for your patience.
Thank you, Dilek. We can take a few short questions if you have anything that you wish to ask. Please feel free. Yes, sir. The viscoelastic that is recommended is always methyl cellulose. High molecular weight viscoelastic not allowed. The reason is if it gets entrapped between the ICL and the crystalline lens, then that will not be able to come out, and it might cause a lot of intraocular pressure rise. So methyl cellulose is what is recommended.
Some surgeons who use sodium alanine saying that it's easier to remove it completely. So there are two schools of thought. One that uses only methyl cellulose, the The other, which uses sodium iodinate, because it comes out in total as a bolus. It's much easier to evacuate, faster to evacuate. Surgeons who are using sodium iodinate also say it's good. They're not had any problems. But sometimes sodium iodinate, you can have impurities, you can get a fast-like reaction if the sodium iodinate is not too good, so you have to be careful. I think it depends upon the individual surgeon, but the company recommendation is to use only HPMC.
Yes, sir. Yes,
That has come across cases of irregular walls, unequal walls on the two sides.
the question is irregular, unequal walls. I have not come across. Shri Ganesh?
Basically, it's the central wall which you look at, and at the edge, basically, it should not be there should not be a touch. You can have one side touching the crystalline lens, and then, but with the V4C, the vault was increased so that you have a much higher distance. The central vault is higher.
I've seen a case where one of my cases where so an irregular vault and on dilatation of pupil, we found that the lens haptic had tucked upon itself and folded upon itself.
Yeah, you can get that.
But that was not there. I reviewed the clip on the intraoperative video, and end of the surgery, the haptic was totally open. It had not constricted the V4 lens, had not constricted the pupil. So till the time the patient left the table, the lens was open. But then this has happened sometimes post-op. So how can one?
See, normally it doesn't happen. I think it is very peculiar. You should report it, that the haptic folding. But sometimes the haptic can get entrapped in the zonules, and you have a higher vault. Then what is recommended by Professor Arambari is basically that you go in, put in viscoelastic and slightly move the lens, shift it side to side so that it settles in the surface if it's entrapped in the zonules. So that's the only thing. But this is actually quite interesting. We have a video.
I have a video.
I have come across with a patient with ICL and dilated fixed pupil. That pupil is not constricting even with pilocarpine or not. So that's it.
Dilated fixed pupil usually occurs if there is a pupillary block, a spike in the pressure, and then there is some amount of pupillary paralysis.
No, that tension is normal. Pupil is there.
Generally, you don't have a dilated fixed pupil. There's no reason unless there is sphincter paralysis.
No, that whatever there in the HC, that is written that because of the inflammation they have put
because of
homite. And after that it's dilated, and after that it's not constricted.
If you have a Uret's kind of a syndrome, you can get a dilated pupil, but because after homite, generally it should constrict. Have you tried putting pilocarpine? Have you tried putting pilocarpine?
It's not responding.
It's not responding to pilocarpine. That means there is some amount of paralysis in the sphincter, probably because of maybe a transient rise. I had one patient with malignant glaucoma immediately after ICL. And we did a UBM, we found that the ciliary body had rotated. Immediately gave mannitol, put atropine, recovered, but then his pupil is dilated and mid-dilated and it's not reacting very well. So if you have a pressure spike, then that can happen.
Yeah, similar experience.
So in that case, we should leave it like that.
There's
nothing else, there's no option. What you can do is, if the patient has a lot of glare or discomfort, you can put a contact lens, a cosmetic contact lens with a pin or artificial pupil.
I also have that experience. The IOP went up. What is very important is to get the IOP as quickly as possible down to the normal limits by giving everything, Diamox, if required, mannitol, glycerol, everything, so that, and a washout, because if it stays on too long, this is definitely what is good.
What I do is I burp the incision. The side port can be burped under topical in a slit lamp using a 26 gauge needle. That's very effective because even with Diamox and all that, they don't respond. There's viscoelastic, the pressure is very high, patient has headache, vomiting. You just go take them under the slit lamp, burp the incision, then the eye becomes a little soft, they recover immediately.
Thank you very much. I think we'll have to close. And thanks everybody for joining us here, and thank you extremely well. Thank you.